Thank you, Suzanne, for starting the recording. And let me welcome everybody. My name is Jeffrey Kahn. I think most of you know me. I'm director of the Berman Institute of Bioethics here at Johns Hopkins. And it's my pleasure to welcome you to one of our bi-weekly Berman Institute seminar series presentations. And today is also one of our twice a year Sheila Hutzler Reeves Memorial Lectures. So let me, before I introduce our speaker today, do a very brief background about the Hutzler Reeves Lectures and what that naming means. So I think many of you know the Hutzler Reeves Memorial Lectures are devoted to palliative care and end-of-life issues, ethics and palliative care and end-of-life issues. And we owe the name and the commitment to host these lectures to Ms. Eleanor, better known as Ellie Trowbridge, and her family, who were very devoted to these issues. Ellie Trowbridge was a member of the Berman Institute's advisory board until she passed away in 2007. She was very committed to the university and to the Berman Institute, and she was very committed to the issues around ethics and end of life because she lost her daughter to breast cancer in 1988, and that was Sheila Hutzler Reeves. And so since the endowment of the lectureship, we have hosted twice a year lectures devoted to ethics and palliative care and end-of-life issues. Today's Hutzler Reeves lecture will be delivered by Susan Block. Dr. Block, we're very thrilled to have you here. By way of introduction, Susan Block is the founding chair of the Department of Psychosocial Oncology and Palliative Care at the Dana-Farber Cancer Institute and the Brigham and Women's Hospital in Boston. She's co-founder of the Harvard Medical School Center for Palliative Care and professor of psychiatry and medicine at Harvard Medical School. She has deep interest and longstanding research commitments and is a national leader in the field of palliative care. So we're really thrilled, Susan, to have you here today. Welcome to Johns Hopkins to deliver a talk entitled Clinicians, COVID, and the Culture of Medicine. If there were a live audience, we all would clap now. Thank you for being here, Susan.
Thank you very much, Jeff. And I'm delighted to be here and to have the opportunity to sort of talk with you today. So Susanna, can we start sharing the screen so that I can, fantastic. And we'll go to the first slide from here. I decided to talk today about this kind of the clinicians, the COVID crisis, and the culture of medicine, because obviously it's something that we're all very preoccupied right now with. And when I planned this, we were probably less preoccupied than we are now with the changes that are happening with the prevalence of the virus. But I'm hoping to take a slightly different tack today than talking about, virology and microbiology and even straight ethics, but to try to look at COVID within the culture of medicine and by focusing particularly on its impact on clinicians. And so today I'm going to take you a little bit on a journey through that. If we can go to the next slide, please. I'm hoping to do this in a very interactive way. I invite you to use the chat function. If you have a little vignette you want to share or reflection, that would be great. I love interruptions and commentary throughout. I'm not sure how easy it's going to be here with Zoom, but if we can figure it out, we can do it. What I plan to do today is to share some reflections based on my experience over the past 6 months or so since COVID started, running individual and group support sessions in Boston during our surge and afterwards. The sessions involved clinicians from virtually every discipline in the hospital. They were entirely optional, and there was a very high level of interest and demand in having a place to talk about these experiences. So this is where a lot of my data comes from. And based on those, and hopefully your own experiences, I'd like to sort of think together about some of the emotional challenges for clinicians in relation to COVID. And we're going to try using Zoom polling technology to be able to hear some of your own reactions to some 3 questions that we thought might be engaging. And finally, I'd like to contextualize what we talk about in terms of clinician experience within the literature that exists on moral distress, moral injury, clinician mental health, and interventions to reduce clinician distress. Next slide, please. I'd like to provide a little bit of the context within which I'm thinking about these ideas. I think one of the most striking aspects of this COVID crisis that we're in the midst of is that it really represents a confrontation with both individual and collective vulnerability and interdependence. It's not like you have heart disease and I don't, so I can feel separate and safe. It's like we all are in a position of vulnerability. Perhaps healthcare professionals are in the greatest position of vulnerability. I think the other piece that I think COVID reminds us of is our interdependence and the fact that how COVID spreads, how we care for each other, the strains in caretaking relationships, both within families as well as between clinicians and patients, are an enormous part of the context within which we are dealing with COVID. And so, you know, we're, as healthcare professionals, we're experiencing and coping with this pandemic, you know, both as human beings with our own webs of relationships and connections, and also as healthcare workers who have a unique set of ethical responsibilities, clinical responsibilities to our patients and our colleagues. And in an unaccustomed way, we as clinicians are experiencing higher levels of vulnerability than we're accustomed to in our work. One of the things that has always struck me is that our culture of medicine has historically had very, very little respect or space for clinician vulnerability. And this is particularly true for doctors, but I think there are elements of it that cross across disciplines. But we're expected to be, you know, cool, calm, collected, focused, competent, expert, and not to be scared. And maybe this is beginning to change as the culture of medicine shifts with different types of people coming into medicine and perhaps a greater tolerance for emotion within medicine. But if it has begun to change, it hasn't changed very much yet. Next slide, please. This is a poem, which I will read to you in a minute. And when I first read it, I thought it was about a caretaking relationship between a man and a woman. But more recently, as I've been thinking about it, I read it as a parable about that can also apply to clinicians as healers and our patients. And I encourage you to reflect in both ways about this poem as I read it. This was something that was written many years ago. It's called Quarantine. In the worst hour of the worst season of the worst year of a whole people, a man set out from the workhouse with his wife. He was walking, they were both walking north. She was sick with famine fever and could not keep up. He lifted her and put her on his back. He walked like that, west and north, until at nightfall, under freezing stars, they arrived. In the morning, they were both found dead, of cold, of hunger, of the toxins of a whole history. But her feet were held against his breastbone. The last heat of his flesh was his last gift to her. Let no love poem ever come to this threshold. There is no place here for the inexact praise of the easy graces and sensuality of the body. There is only time for this merciless inventory. Their death together in the winter of 1847. Also, what they suffered, how they lived, and what there is between a man and woman, and in which darkness it can best be proved. I think we in healthcare are exposed to stories like this all the time when we watch our patients and their loved ones engage in the moral act of caregiving and care receiving. What we think less about is the moral act of caregiving in our clinical roles. And today that's part of what I would like to focus on. Next slide, please. As I think we're all experiencing, we're kind of at an inflection point with COVID. The spring surge, is behind us. I understand that there was a surge here and that many people were involved in caring for patients during that period of time. Many of the clinicians who were involved in patient care during that time are still dealing with the after effects of COVID experiences. We've all been living for many months in masks and in socially distanced ways, which has cut off many of our sources of pleasure and connection that are part of how we all keep going. We're seeing cases that are growing terrifyingly across the country and are reaching unprecedented levels. I think that from my point of view, and that other people may see it differently, the national COVID leadership has been inadequate, confused, and politicized. But at the same time, we've learned a lot about how to take care of COVID patients better, and mortality rates appear to have fallen. But right now, we are standing kind of on the threshold of this worsening pandemic, and we don't know what to expect as it grows further. And I think that there's a pervasive sense of dread about what's ahead. One of my patients said to me, well, with COVID, everybody knows what it's like to have cancer. And I thought that and what she was talking about was that dread. And I think we're all experiencing different versions of that. Next slide, please. The common kind of emotional foundation, I think, for what we're dealing with in the midst of the pandemic is processes of change, loss, and grief. And trying to understand what the changes are that we're going through, what the losses are that we're experiencing, and giving ourselves space to grieve those losses, I think, is part of the ways we develop strength and resilience to face what's ahead. We all know that this past year has brought with it unbelievable changes in our personal and professional lives. This meeting taking place on Zoom is a manifestation of that. But the other part that's going on is that each of us individually is having a lot of different losses that have come from our COVID experiences. And most of them are very private, the sort of superficial but important ones are things like missing a planned vacation. They're very deeply hidden ones, like learning that we're more afraid of being exposed to a communicable disease than we thought we were, and feeling more scared than we think we should feel. A big one, a huge one that some people have had to confront is losing a loved one. And all of us, I think, in one way or the other, are feeling cut off and more isolated from colleagues because of remote work. These losses affect how we go into any new challenging situation. And part of the human need in dealing with a loss is to allow ourselves to grieve. A lot of time we're grieving and there's a kind of discomfort, dysphoria, unhappiness, misery, without us realizing what's going on. I would argue that a big part of sort of pandemic misery has to do with grief for all the losses that we are enduring. And grieving makes us more vulnerable to the external environment and more prone to experience our internal environment in a negative way. Next slide. Okay, now this is time that I'm going to sort of throw it back to you. And I'd like to use the Zoom technology to reflect back on your experiences with COVID, both personally and professionally. And I'd like you to identify of this list the 3 most significant losses that you have experienced. And please note that the list goes a little bit beyond the slide here. So what I'd like you to do, you don't have to rank order them, just identify the 3 most important ones. No one has access to who responded what, so please respond, as yourself as much as you can. And what we will do is we will present when everybody's had a chance to kind of vote. It's a voting season. We'll have a chance to see how this audience answered this particular question. So please go ahead and vote. And I'm just going to ask a side question to Suzanne. Can you see how many votes are coming in?
I can.
Okay, great. So you tell me, I can't see that. So you tell me when you think it's a good time to stop the poll when most people have responded.
Will do.
Thank you.
Give me one sec.
So this is not science, just to be really clear, but it is a way of understanding each other and what a collective experience feels like. Okay, so social isolation from this list is far and away, I think, maybe not far and away, but is the top one, paired with disillusionment with our country at very high levels. And the next one is a kind of the loss of confidence in the future. A small number of people have experienced the loss of a loved one or personal health issues. Family disruption is also a very large one. A loss of confidence and belief in myself. It's affected spiritual well-being, the feelings about the healthcare system and economics. So these are pervasive losses. And, I think there's some that are common and some that are very unique. And part of, I think, what we need to do with our patients and with our colleagues is to sort of be aware of the breadth of these concerns and what the commonalities, and to explore the individual responses and to learn from our colleagues. So let's see, I'm going to, can we close this? Okay, and go to the next slide. And if anybody has the impulse to, share a little vignette or a little story about one of these losses, you're more than welcome to do that in the chat, and we'll return to them in the question and answering period. These are some of the kind of collective vulnerabilities that we're facing. For many people, I think in healthcare, I've heard this over and over again, COVID is a life-defining crisis in the sense that we went into medicine, nursing, social work, chaplaincy, whatever it is, to take care of patients. And this pandemic has sort of challenged our comfort and willingness and bravery and courage, in a sense, to do this. And I think most of us have had somber moments of reflection about who we are, what risks we feel able to take, what risks we don't feel able to take. And that has been a source for many people of distress and disappointment in themselves. Obviously, we're all dealing with massive change in the way we live and the way we take care of patients. And just to name this, change is stressful for people. and people don't like it. And we're having to adapt to extraordinary numbers of changes very, very quickly. And then we have to adapt to the change in the change that we just adapted to. And that process is incessant. As we talked about, that there are these sort of, big and small losses that we are all kind of confronting, and this sense of threat, not just to ourselves, but to the people we love, and to broader issues in our world, which I'll talk a moment about talk about in a moment. Isolation. I think one of the big issues that has been brought to the fore and to our attention in a deeper way has been the incredible disparities in who gets this virus, in access to care, in outcomes. It has highlighted some profoundly wrong things, both with our society as well as with our healthcare system. And I think we've all been sobered by an awareness of that and more conscious. There's been economic devastation, perhaps not so much within the healthcare sector, but if you talk to people in other parts of our society, economic problems are a huge vulnerability, going along with concerns about job security. We've had to face all these, the pandemic in a sort of a situation of the intensification of political polarization, where wearing a mask or not wearing a mask has become a political statement, and where the science has been politicized, where there is an enormous amount of misinformation and disinformation that has been propagated about the virus, and where people have vastly different understandings of what the threat is that we're facing. The pandemic also is a reminder of the fragility of the ecosystem in which we're living, and about how pandemics get started and how they spread, and how globalized we have become. I think, as the prior slides suggest, there's a lot of anxiety about the future. And with all these negative things, we're all looking for something to hope for. And people have found it in different places, but I'm enumerating these in this detail because I think it's very easy to just say, oh, this is my life, I have to deal with it. But if you were to put these stresses, losses, vulnerabilities on a scale of a stress scale, you would be, on beyond zebra, like on further than at extraordinarily high levels. And this is just at our baseline. Next slide, please. I'd like to dig now a little bit deeper into the unique aspects of the clinician experience. And the first and most important thing is we're all new at working in a pandemic. I mean, I guess there are a small number of people who are involved in SARS or the H1N1 or Ebola, but most of us are newbies at this. And so we're having to learn. I think one of the things that has been, at least in my experience in listening to people up in Boston, that has been the most distressing, this comes at the top of the list consistently among my colleagues in Boston, is what has been referred to in other settings as family separation policies, but these are policies that mean that only the patient is alone for most of their care process in the hospital, and that has been a source of enormous moral distress and emotional distress for our clinicians, particularly early on. The lack of PPE and testing has been a major concern for healthcare providers. We haven't felt safe doing our jobs because of problems with supply chains, communication, and so on. And we've been having to face the concern about inadequate numbers of ventilators and ICU beds. We're now bringing with us experiences from the spring from working in COVID, the distress, the trauma, a persistent exhaustion, in some cases demoralization from that experience. My own observation was that people during the initial surge went into a sort of survival mode. They did what needed to be done. They were kind of numb. They proceeded as best they could. And then as the surge let up, there was an enormous pervasive sense of exhaustion, emotional exhaustion, physical exhaustion too, but emotional exhaustion. And people really had trouble kind of processing anything. And they just were sort of shut down and exhausted. And then what's happened over the summer and early fall is that as some of the exhaustion had passed, there was kind of an ability to think more, process, work through some of the issues that I'm going to go into more in this next segment. And now in late October, early November, there's this sort of sense of anticipatory re-traumatization that the clinicians who were at the bedside in COVID and doing whatever stressful jobs they were doing, are feeling kind of anticipatorily re-traumatized, even though the numbers haven't gotten to extremely high level. I think the clinical helplessness has been a big deal for clinicians. We're in healthcare, we are all sort of competence junkies. We like to be able to be competent, to know what we're doing and to do it and to see results. And COVID has really been the antithesis of a situation in which that's been possible. We're going to talk more about moral injury, but in the next segment, but worries about one's own health of the family, the isolation that clinicians feel, the feeling, and I heard this a lot was about, I really can't talk about this with my family because they don't understand, and I don't want to upset them to tell them what I've been through. My friends don't understand. They want to go out and drink beer at the bar, and that's the last place I want to be. And I just can't be, in that fun-loving state with this much heaviness on my shoulder. I think that we were all scared in certain ways, or many of us were scared by watching some of our colleagues, both locally and in other places, experience major mental health challenges and getting COVID, and in some cases dying. And so this fear about the well-being of our colleagues is something that I think we all carry with us. And if we're scared for them, we're scared for ourselves. The stresses of homeschooling and taking care of older parents and managing our institutional clinical roles has been very hard. I think in many cases there was a feeling, and I can speak of the experience in Boston, of inadequate institutional support and communication. And I think in efforts to try to reassure people, hospitals downplayed the importance of PPE earlier. And it had a very huge effect on the trust of our clinicians in the hospital, making them feel like we know PPE is a good thing. We use it everywhere else. Why are we saying that we can get by with the same, fraying surgical mask for a whole week of taking care of the most infectious people we've ever taken care of? And so I think that issue has that lack of the distrust has stayed with many people and is still part of the ecosystem that we're living in. I think another major stressor for clinicians has been working outside our own areas of expertise. And, those of us who are pulmonologists and comfortable in the ICU, are kind of in your element, although we still don't have the treatments that we would want to have. But people who have stepped up and stepped into new roles, including, in my hospital, a dermatologist running ventilators in the ICU for periods of time. People have been in really scary, uncertain, roles where they knew that they weren't the best person to do those roles. And we were really in a very bad state that these people needed to be deployed. We're called heroes, but many of us don't feel like heroes. And we may feel inadequate and guilty and even ashamed about our failures. The idea that we're heroes when we couldn't save so many people, that we, when we feel that we didn't know how to take good care of many of these people, where we look back and we say, oh, we shouldn't have been doing that. We shouldn't have intubated so many people so early. All those things, that kind of dissonance between, oh, you're supposed to be a hero, but you're only too aware of your own failures. And finally, the other big thing that I think has affected the clinicians has been overwork. And many people in my institution did massive amounts of on-service work to try to take care of the volume. It was striking to me that ICU docs who were in the intensive care unit for 5 days a week for 4 weeks at a time felt that they hadn't done enough. And this is also, I think, something about the medical culture, is this idea that we step up, but this idea, when is it enough to stop stepping up and to take care of ourselves? And that takes me back to the quarantine poem. How much are we expected to be the last heat for our patients? That's part of our job, but where are the limits? Next, please. Now I want to talk about moral distress, because I think that's been one of the key elements that has contributed to the burden on clinicians. I want to say a little bit about the origins, which, the idea about moral distress and moral injury really comes from the military, but it was brought into the healthcare world by nursing, by Janitin, and Cinda Rushton, who is at Hopkins, has been one of the leaders in formulating our thinking about moral distress and moral injury in healthcare. And I think we all owe the nursing profession a debt of gratitude for the teaching that they have done to all of us about this issue. Moral distress occurs when clinicians can't act in accordance with their own moral beliefs. 70% of residents describe having moral distress at different times, about a third to a half of nurses. And it creates a sort of sense that you can't act with integrity in those situations. Moral distress is often generated by systemic uses. If they're not good resources, if they're conflict of interest, if the support systems aren't adequate. And next slide, please. But it has a very interesting double-edged value. I think moral distress can be a good thing in certain respects. We don't think of it, distress is a good thing, but it reminds us that healthcare is a moral practice and that we need to pursue it in an ethical way that has integrity. And one of the ways we assure that we are doing that in an ongoing way, in crisis, in high clinical demand, is through this process of questioning the care that we give. And that is a way of checking in with our own moral compasses and also learning and growing as clinicians. It's a signal to us that our care processes, our clinical values might be going off track. And in that sense, I think about moral distress as really an incredibly precious aspect of clinical practice that gives us opportunities to grow. It can, help us. I've spent my whole career building the field of palliative care because of my moral distress as a medical student and intern about how patients at the end of life were treated. And, 40 years I've been working at it. A lot of work still to go, but moral distress can lead people to develop new ideas about how to make these problems better. Even though there are a lot of opportunities for individual and team growth and development, the power hierarchy often subverts this opportunity by some of the ways that it can be ossified and change resistant and ingrained in usual practices. Next slide. Let's go back one more. One more, sorry. I think you're going forward.
I'm sorry, give me one
That's
second.
okay, no worries. Moral distress obviously can also be a bad thing. And that's the name of the slide that we want to get to. Yeah, okay. You had it just there. Okay. One of the big problems is that the kind of moral distress that we feel in a situation, one more back, of COVID, is taking place in the midst of a real crisis. And it's very hard to do system fixes in the midst of a crisis. You can identify what needs to be fixed, but it's really hard to do it. And the problem is that because the system can't be responsive and people are overworked and all the stresses on the system means that clinicians can be left in a state of helplessness. And helplessness we know from sort of the literature about psychology, is a very sort of dangerous psychological state to be in. And the kinds of things that we do, advocating, making change, that can be antidotes to helplessness, may not be as effective, or we may not have the energy in the midst of a massive crisis to be able to do these things. And this is where we need to move towards sort of coping and resilient strategies for dealing with moral distress. Now, next slide, please. I'd like to invite people now to answer this question and to look at some of the aspects of the COVID experience in your professional life that you have found most distressing. And so we'll give you a minute, and then Suzanne will put up the responses. Think we're good to go, Suzanne? So here we see the biggest source of worry is about the health of family. The next biggest is suffering of patients of families and isolation. Personal health worries, PPE availability, juggling multiple roles, not being able to do enough, finances, job security are all sources of concern. So that, there are a lot of different things that people are worrying about, and each worry set is different. Okay, onward. Next slide. So moral distress occurs when, moral injury occurs when clinicians are expected to make choices that transgress longstanding, deeply held commitments to healing. It's often an outcome of prolonged moral distress and helplessness, and is associated with shame and guilt. And I think that's a big part of what we hear from the clinicians who took care of COVID patients in the spring. The shame and guilt comes from this feeling of had a moral injury. Sometimes it gets confused with burnout, but it's not the same as burnout. But moral injury often leads to burnout, post-traumatic stress disorder, depression, and suicidality. Suicidal is rare. Next slide. There are a number of risk factors for post-traumatic stress disorder, difficult pre-COVID life events, psychiatric disorders, direct traumatic exposure is a critical one. And I want to pause here because I think one of the big differences that has emerged in my mind is the difference between the traumatic exposure of physicians and nurses. At least in our experience in Boston, the nurses were at the bedside. The nurses are always at the bedside, but the nurses were at the bedside to the most extraordinary degree that I've seen. You know, a nurse spending 6 hours with 2 ventilated patients in a room, not coming out of the room once because all of the suiting and unsuiting and the patient's needs and everything else. The nurses are the people who have really spent the minutes and hours at the bedsides of the patients. Doctors have as well, but I think the reality, at least in Boston, is that most of the work that the doctors did was sort of outside the room. And the direct experience of holding an iPad up to a patient for their family to say goodbye, dealing with the day-to-day physical care of prone patients, dealing with the physical suffering and emotional suffering of the patients in that setting was extraordinary. And I think that my own hunch is that when we start getting more data, that the traumatic exposure will come out as being much worse for nurses and put them worse risk for post-traumatic stress disorder. It's also, PTSD is more likely to happen when people are asked to do things outside their normal responsibilities and when they perceive themselves or their loved ones to be at risk. So COVID is a moral injury, post-traumatic stress disorder incubator in a lot of ways. Next slide. You know, the things that help during COVID, during the acute phase, are availability of appropriate resources like PPE, normalizing and destigmatizing distress and help seeking for clinicians who usually, you know, are avoidant. Good teamwork, good team support, and check-ins that include a focus on emotional well-being are absolutely critical. Having support for difficult decisions from colleagues, from other consultants, from the organization, patient relations, whatever it is. Our experience was that palliative care engagement and resources were incredibly important in getting through the COVID crisis. We had palliative care clinicians in the ICUs, in the emergency departments, really engaging with the nursing staff and the rest of the medical staff on goals of care conversations, on symptom management, and on family support. And I think that that's a critical element of reducing moral injury and moral distress. Ethics consultation obviously is an incredibly valuable resource for these complicated decisions that sometimes need to be made where the ethical answer is really up in the air. Individual outside the work team, individual group support and debriefing, you know, rest, nutrition. And I think that there's a role for prevention. And this is where I think we've kind of missed the boat on the second surge. A lot of work. I think we began to do a lot of work on having earlier advanced care planning conversations with patients with serious illness in the community as a result of the urgency of trying to avoid invoking crisis standards, but it really hasn't continued in the way we would have hoped it would have. But it is an opportunity because that reduces moral distress from the clinicians that comes along with invoking crisis standards. Next slide. I'm just going to say briefly a summary of mental health issues in clinicians in pandemics and other situations like this. There was a 75% reported psychiatric morbidity in China during the SARS crisis. Similar 57% reports of moderate to high anxiety during H1N1 in Greece. These data are not great, but we don't have the good COVID data yet. There certainly appears to be have been elevated distress, burnout, and PTSD in the clinicians who treated SARS patients. And as we said before, direct contact with patients leads to more post-traumatic stress and more distress that tends to be higher in women, parents, younger clinicians, and people who had a personal COVID diagnosis. We need to remember also that non-clinical staff, the housekeepers, the dietitians who interact with patients, albeit indirectly, are also incredibly vulnerable to these same kinds of issues, but they receive less information, less support, and feel more disempowered. Next slide. I want to say one thing about the role of institutions, that I think we need to recognize that institutions have a responsibility for the emotional well-being of their healthcare workers. Good crisis communication is essential. Information, empowerment, transparency are really critical. But the institutions also need to make things easy for the clinicians, with screening available on site, easy testing on site, peer support, individual outreach and support, and focusing on to change the culture around vulnerability and stigma of needing support. Resources are needed to make all this happen. Clinicians need time off when they are in a place where they really can't do more in a healthy way. And we need staffed support programs for clinicians and other healthcare workers. Next, please. It's important to remember most clinicians are resilient. Support groups are valuable for those for whom they're valuable. They don't work for everybody, and some people do better with individual outreach. Suicide occurs, and we need to be mindful of that as a risk, but it's rare. And I think we need to remember that post-traumatic growth can occur. And I heard from a number of clinicians some versions of, I stepped up in the biggest crisis moment of my lifetime. And I heard that said with pride and a sense of accomplishment that were very moving. Next slide. And this is our last poll. I'd like you to reflect on, here, let's put up the poll below. Is a list of positive changes that people have experienced during COVID. And another way of asking this is, what have you gained since COVID? And please identify the 3 items that are most important to you. Okay. This interesting, I have a clear understanding of health inequities. I think this has been a major silver lining. This is what I heard in Boston when I used some of these same polling questions, that we see it and we feel it and we know it in a deeper way. Other things that people saw as valuable, family life has become richer. Being home has had some benefits for our family lives. And we feel there's a feeling of greater contribution and of greater closeness with our colleagues. 9% said there was nothing that was better, and that's a sort of very understandable response. But I think just to look at this, that I have more of a sense of community, more time for myself, that there are some silver linings in this that I think are important for us to recognize. Now, next slide, please. And then we're at the end here. So, in closing, just to remember, this is a time with lots of changes, losses, and challenges. we're having all these intersections in unprecedented ways. I mean, I think who would have thought that COVID would have made family life richer, and yet it has. So that there are good things and there are bad things. There are bad ways that it's had an effect as well. It's a huge stressor for our society, institutions, and each of us as clinicians and citizens. We need to remember who's most vulnerable, and that people who are at the bedside, who are providing direct care, are at the greatest risk. That connection and good teamwork palliate distress. They're the best palliators we have. We can grow in the middle of this terrible time. The most important things are to look out for each other. And I think there is a real value, as Shakespeare said, in giving sorrow words, to allow ourselves to speak about the losses that we're experiencing when the time is right. Thank you very much, and happy to take questions.
Thank you, Susan. That was really excellent. Let me try to make myself a little brighter. There we go. I think, Joe, you were going to manage the Q&A discussion for us.
Yeah, sure. Happy to. And I see we have a few hands raised, so maybe I'll ask Suzanne if you could make me either a co-host or if you'd go ahead. There we go. I'm unmuting you, Cinda. If you'd like to speak, please go ahead. Feel free to ask a question or make a comment.
Hi, Susan.
Hi,
Great.
Cinda.
Oh, great to see you. And thank you for a fabulous presentation. I was really struck by the sort of shared experience, both Boston and here, and wondering what your thoughts are about what is the next opportunity in the professions to be more proactive in trying to provide the resources that clinicians need to meet these challenges. One of the worries I have is that, some organizations have stepped up to provide resources, but it's often a short-lived investment. And just wondering what your thoughts are about, sort of creating a deeper infrastructure to anticipate and respond to these issues.
Yeah, that's a great question. And I wish I had, a great answer. I have a couple thoughts. One is we really know so little about how clinicians are dealing. That's one of the things that really strikes me. It struck me when I was doing the literature review, and it struck me in our own setting. We're just launching a survey of clinician coping during the surge. It's taken us this long to get it through the IRB and everything else. But I think we need to know more about clinician responses. And it needs to be, sort of theoretically grounded and all those good things about doing good research. And we need to know about it across different settings, since settings have such individual kinds of conditions. So I think that'll help anything we do in terms of planning. I guess the one thing, I think you were kind of alluding to this, I have a lot of skepticism about how well interventions that are not closely connected to the bedside and with an understanding of some of the complex dynamics that take place in the process of providing care. I have a lot of trouble sort of seeing how that those can be valuable. I may be wrong about this, but one of the things that I've learned from the groups that I've run is that clinicians want to speak with clinicians. And we've run all these interdisciplinary groups, and they want to speak with other clinicians who took care of COVID patients and who understand some of these experiences. And I think, and we have to be more aware of the right timing for these kinds of interventions, because I tried to do some of this prematurely and people just couldn't do it. It was just too hard. People were too exhausted. They were too still kind of much in survival mode. And so I think we need to harness what we've collectively learned. And I understand Hopkins is doing some interesting things with peer support. Columbia is doing, we've been doing, there are a lot of, we need to start talking together about what these experiences have been and kind of harvesting whatever learning we can to better provide services. Because I don't, the people, the hospital says, EAP, and our clinicians haven't found that particularly helpful. And I think one of the key things is being perceived as on the clinician's side and being able to see the clinician's perspective. And that was one of the things that I heard most prominently from nurses, that EAP they felt was sort of corporate. And the clinicians are looking for clinicians to help work these issues out with.
Yeah, great. Thank you.
Sorry, muted here. Karen, would you like to ask your question? You're welcome.
Yes, actually, it's first I just wanted to say what a fantastic presentation this was. Thank you so much. A lot to think about. I was just wondering, in your analysis, if you've taken into consideration the gender of the individual, the age of the individual, because it seems like people that are dealing with young children and these stresses have not harder or easier, but just different than older clinicians who have made concerns about their own health. Just different varieties of questions and interests. And so I think gender, I think age, I don't know about other sorts of demographics. Certainly the financial implications also, if a spouse has lost their job or if they're a single parent. And when I was trying to answer these things, I'm not a clinician. So certainly some of these questions weren't relevant to me, but I still felt my daughter is a clinician, so I could sort of sense some of the things that she has said. But I was just wondering if you're doing any analysis or you're taking those things into consideration.
Yeah, well, I think the preliminary knowledge that we have suggests that younger people are more at risk of having a tougher time, and that women are. And, but we don't know whether it's because of caregiving responsibilities or different levels of empathy. We don't know why, but that there appears to be some differences. We don't have, and this is all from data from slightly different circumstances. So I haven't seen published data from any place about the COVID experience and the impact on clinicians. There's there are a bunch of papers. They're not database.
Yeah.
And so we need that data. I think, as you said, the issues, one of the things that just anecdotally was very interesting was the older clinicians like myself and clinicians who have health problems had an enormous sense of not stepping up and of a sense of letting themselves and their colleagues down by not being in the hospital. And that's a whole different, moral injury. Than other people, than we've sort of conceptualized in this process. But I think it's another kind of moral injury. And so we really need to go sort of deeper into this to try to understand, so that we're not making assumptions about what's going on for different people.
Yeah, thank you.
Well, thank you, Susan, and thank you everybody for the attention and the really interesting comments. Susan, your presentation was really interesting, remarkably insightful, and I think we all learned a lot today. So thank you for being with us. And again, applause would be raining upon you if we were all in the same place. So thank you for joining us, albeit virtually. And as we close at top of the hour, as we always do, let me remind everybody that we have another seminar 2 weeks from today, November the 23rd. Presenter will be Patricia Kingori from Oxford University, talking about fake medicines and fake therapies and their implications for global health. So with that, thank you all for attending, and thank you again, Susan. We'll see you all soon.
Thank you.